There are many ways in which perinatal loss and fetal loss can be defined, the definition not generally found to be consistent across journal articles. According to the Center for Disease Control, CDC, in 2006, fetal mortality can be defined as the intrauterine death of a fetus at any gestational age prior to delivery. Perinatal mortality can be defined as infant deaths under age 28 days and fetal deaths at 20 weeks or more. Statistics exclude data for induced terminations of pregnancy. In 2006, there were 25,972 reported perinatal deaths at 20 weeks of gestation or more, but the National Center for Health Statistics National Survey of Family Growth estimates that there are more than 1 million fetal losses annually in the United States, many of which are prior to 20 weeks of gestation. Social workers may intervene with clients on a variety of levels. By assisting with the mother and father directly following the loss, they could also address this family and accentuate the parent support system, and also address the issue on more of a macro level by advocating in areas for various support and time for grieving. Parents can be affected in a variety of ways, such as depression, PTSD, normal grief, complicated grief, and anxiety over future pregnancies. According to the 2008 article, An Exploratory Study of the Psychological Impact and Clinical Care of Perinatal Loss, multidisciplinary teams provide support within a hospital setting. Encouraging parents to hold or see the baby in some way have direct contact with the dead or dying infant is common. Some hospitals also provide support groups and the services of a chaplain or social worker to help with grief and funeral plans. Some states actually legally require this support. Oftentimes, a social worker or bereavement counselor follows up some weeks later to assess the couple's coping and if further support or mental health treatment is necessary. Despite this being common practice, a retrospective cohort study indicates that women who saw and held their deceased babies reported depression and PTSD symptoms of significantly higher severity when compared to a sample who did not. This points to the idea that common practice may be counterproductive. Other studies have also noted that higher, more intense symptoms were shown the further along the mothers were in their pregnancy when the perinatal loss occurred. Social workers should take into account that social support is a strong predictor of recovery and decreasing maladaptive coping after perinatal loss. It contributes to a healthy long-term response. Implications for future practice are that if a social worker provides a more extensive clinical interview or screening, healthier adaptation to such a loss could occur. Another time period in which a social worker might be utilized would be during a pregnancy following a perinatal loss. In the article from 2011, Emotional Cushioning in Pregnancy After Perinatal Loss, what is called emotional cushioning is operationally defined and found to be the actions of women holding back their emotions to avoid prenatal bonding in the case of another perinatal loss. Positively related to the level of emotional cushioning is the amount of anxiety women face during this pregnancy, and two conflict themes emerged: conflict between despair and hope. With this conflict, a middle ground was difficult to achieve between expecting the worst while remaining hopeful, and emotional cushioning allowed mothers to find this balance. The article Pregnancy After Perinatal Loss, an Association of Grief, Anxiety, and Attachment also details that weak prenatal attachment is associated with pregnancy directly following grief, the stage of the prior lost pregnancy, late loss, and the number of losses, also indicating risk for grief symptoms and high anxiety. A social worker may perform in such a way as to decrease symptomology but perhaps enhance emotional cushioning. Another thing social workers need to take into account is the age of the mother in case of teen pregnancy. The article Anticipatory Guidance, a hospital-based intervention for adolescents with perinatal loss, describes how to effectively work with women in this population. It details that social workers must understand the developmental stage of the mother and approach them in a receptive posture, taking into account the mother's acceptance of pregnancy, the meaning of the loss to them, emotional strength they might have, environmental resources, and risk factors. With this form of loss, social workers can be sure to be involved in grief counseling and also counseling through the later birth of a child while advocating for bereavement services in a variety of settings, such as a hospital setting. A strengths-based perspective may be highly conducive to future healthy coping of mothers with perinatal losses.